right, perfect. Well, welcome everyone to the APP course. Now, it's always an interesting challenge starting first. Now we're all awake, we're freshly caffeinated, but as we start to lose our caffeine levels, I know I'm contending with the breakfast taco-itis. So please try not to fall asleep. I'll try not to be too boring on this one. As we go through this upper GI section, I really want you guys to think back to when you had breakfast just now. Think back to your patients and how having any of the diseases that we're talking about or the conditions might have affected how maybe they had breakfast. Take that every meal, take that every single day, always thinking back to who we treat first. So I'm starting off today with EOE and other eosinophilic gastrointestinal disorders. Long topic, but we'll break it down, we'll get through this together. And like Dr. Tell said, I'm at Procomrie Medical Center. I'm the program director of the fellowship there. So this doesn't work, or does it? It does work eventually. Okay, a couple disclosures and disclaimers there. So what we're going to talk about today, we'll talk about the new nomenclature for eosinophilic gastrointestinal disorders. From now on, I'm calling them EGIDs. All right, I stumble too much over my words. We'll talk about eosinophilic esophagitis. That's EOE from now on. I stumble over my words. So we'll talk about how we diagnose it, so who gets it, maybe differences in how those patients present. How does it look when you get your scope reports? Hopefully it's a scope report that's not been scanned a million times in fax, so you can actually see something that's going on. And then our histologic diagnosis, so maybe what our pathologists may say to diagnose. And then how we treat it. Medical therapies, old ones, new ones, endoscopic therapies, and then the emerging role of dietary therapy and how that's really changed over the years as well. These are our nomenclature. So EGIDs are just named by where they involve. So EOE is the esophagus. I'll spend most of today talking about eosinophilic esophagitis. Now the stomach, gastritis, anywhere in the small intestine, enteritis, colon and rectum, colitis. That's it. You would think that this would have been something we've been using for a long time, but it wasn't until about a couple of years ago when a bunch of eggheads got together at a conference, probably in some really nice location, that they came up with this. I would love to get paid to go do that. So if anyone knows anyone on these committees, please let me know. What is EOE? So it's an allergen and immune-mediated inflammatory disease of the esophagus. I promise I'm not going to do too much biochemistry here today, but basically, as you can see from our picture, the infiltration of air. Does it work? It does work. Okay. Infiltration of various aeroallergens or just ingested allergens, so milk, gluten, soy. It acts on the epithelial barrier of the esophagus, which is weakened. It'll penetrate into the squamous epithelium and lead to basically our issues of EOE. We'll talk about how these can necessarily prevent. The inflammation over time leads to fibrosis, dysmotility, which can lead to issues of function of the esophagus, so dysphagia, food impactions. Generally, this is just believed to be secondary to exposure to allergens over time. Although there are some predisposing genes, we're not really going to discuss most of those today, because those are really all kind of in the research realm at this point, not in things that we can clinically test for our patients. Why does this matter? The incidence and prevalence of EOE is rising, particularly in the United States and Europe. Now, some of that is thought to be from the ease at which we can diagnose it with just getting EGDs on people much easier. But even still, when they've gone back and look at, when the creepy pathologist pulls out the old slides that he or she has and looks at the old slides from years ago, the incidence is still increasing beyond what we would have even expected with the new stains of today. And it's just a quick graph to show that, yes, the lines go up as time goes on. It's something that you will see. If you haven't already seen, you're going to see it, and you're going to see it more and more. That's why these are very important. The challenge with EOE is that it'll present very similarly to other GI complaints we see commonly. So most often, someone will come in complaining of dysphagia. I have trouble swallowing, or something kind of that ilk. Up to, in some studies, about 1 in every 8 to 1 in every 4 patients will come in presenting for dysphagia, especially if they undergo an EGD for that. That's a common finding from there. We'll get that out of the way. Otherwise, when they'll go to the ER, it's for food impactions. More than half of patients who come to your emergency departments, or you get called from the emergency department for a food impaction, will actually have EOE. The nuance is that they may present differently based on their age. Adults, these are these classic symptoms. So dysphagia, heartburn, food impactions, maybe some chest pain when they swallow as well. Kids will be a little bit differently. So they'll present a little differently. You'll see feeding intolerance, food avoidance as well, failure to thrive, and maybe even something as generic as abdominal pain. So who among us who's either seen kids or has kids has someone complaining of abdominal pain? Pretty common. So something you need to keep kind of on the forefront of your differential diagnosis. And then they may have pre-existing atopic or allergic conditions, so asthma, allergic rhinitis, or atopic dermatitis, or just your run-of-the-mill eczema. And some of these treatments actually cross over between those diseases as well. I always ask my suspected EOE patients, or someone coming in with dysphagia, or when I'm following up my patients, about their dietary behavior. So they'll still be eating here very slowly. They'll still have a full plate while everyone else has been waiting and they've turned into a skeleton. So oftentimes they'll need a lot of liquids with their meal. They'll cut or puree foods very small. They'll be slow eaters. So rather than read all these to you, or this mnemonic came from the late great Equal Hirano from Northwestern University. I'll tell you a quick story here. So when I was a fellow, I was with Dr. Owen and a few other of my colleagues, and we decided to go to a Spurs games. They were playing the Warriors, and that was when the Warriors were winning championships, so why wouldn't I want to see them play, right? And the Spurs too, don't get me wrong. Well, we bought our tickets kind of late, and we were fellows, so we weren't, raking in the dough like military doctors do. Wink, not really. And we were sitting way in the back. Like, you probably needed some oxygen. I was feeling a little lightheaded how high up we were. But in front of us was a fraternity from Texas State University. Saw a young man in front of us between the first and second quarter. He and his fraternity brothers go down and they need some food. So he comes back with a hot dog. And I noticed that on his little tray of hot dog, there's a massive quantity of ketchup there. So as I mentioned before, maybe modifying foods or using condiments. He's got 2 waters, and he's wearing cargo shorts. He's got 2 waters in his pockets. He's carrying a water, and his girlfriend's carrying 2 waters too. So he's needing to have a lot of liquids when he's having this. Over the course of finishing his meal, his fraternity brothers make fun of him, how much water he needs to drink. He finishes all 4 of the waters that have been brought with him. He's taking very small bites. To finish 1 hot dog, this presumably 18 to 21-year-old took all of the second quarter, some of the third, and even some of the fourth. He's taking really tiny bites, and he's chewing a lot while he's doing it too. Prolonged eating times. So rather than he's not in the military, I'd give him my card, but at that point, these are the kind of patients you want to ask about these behaviors: needing condiments, having to chew, long meal times, having to drink a lot. These are how these people present. I'd be willing to bet, a lot of money that young man had eosinophilic esophagitis. Generally, how we diagnose is classic findings on endoscopy, which we'll go over in a second, and with histology as well as needed. A normal esophagus should not have eosinophils in it. We need to make a cutoff somewhere, so we say 15 eosinophils for a high-power field. That'll be on your pathology reports from the endoscopy that you'll see afterwards. Now, there's other causes of eosinophilia as well. But like I said, generally, unless mixed connective tissue diseases, Crohn's disease, those aren't present, it's eosinophilic esophagitis. In the past, we used to require a trial of proton pump inhibitor therapy to see if this responded prior to the diagnosis. No longer needed. If they have eosinophils, they have EOE. Findings that we'll see are ones of inflammation, so edema, exudates or microabscesses, those eosinophils in the esophagus, or findings of fibrosis, those rings, those furrows, the stricturing, as sometimes we say as a buzzword, trachealization. My first-year fellows will go down, they'll see the trachealization, and they'll immediately pull out because they think they're in the airway, but they're actually in a really bad EOE esophagus. But it's scary for me too. I don't blame them. I'm like, oh my God, they went in the wrong direction. You'll see as it becomes more used in the clinical realm, endoscopic reference or EREF score to document the progression or the improvement in their endoscopic findings throughout their treatment. Since this is just the algorithm right here, as I said, it's gotten super easy now. They come in, suggestive EOE, we do a biopsy, greater than 15. As long as there's no other causes we might think about, they've got EOE. Super simple. I love this. This is something I can understand. And these are our EREF scores here. I don't mean to belabor these points. We won't read them all out. But basically, as the score gets higher, the esophagus gets worse. That's all it is. So let's talk about how we get this stuff treated. So I must say that EOE has more FDA-approved medication than EGIDs, which is 0. So there's some options here for us. But let's think back to what we're trying to do with our therapy. So we need to improve the symptoms of esophageal dysfunction. We need to get them to swallow and improve their quality of life. Maximize nutrition. This is particularly important, as I mentioned, in our pediatric patients. We'll see that failure to thrive. We need to make sure that these kids can grow, they can eat properly, and have a normal functioning life. And then we need to prevent complications of remodeling, of fibrosis, so we don't need to do dilations. They're not coming to your ERs with food impactions or anything of that nature. So combining all those, we're trying to get in this center area of complete response. And there's different things we can do for that. So maybe, this person right here at number 2, their symptoms are great, their endoscopic activity is minimal, maybe because either they're more inflammatory or maybe they just had a dilation. We haven't really fixed the key cause of the issue, but they're going to feel a lot better. But we combine all those with meds, with your endoscopist, to get to this complete response in the middle, complete remission. To use the IBD realms nomenclature, which we'll see a lot later today, this is really in its nascency of getting to the treat to target realm. So again, our symptoms, our histology, and our endoscopic activity, all 3 of those really matter in these patients. And that's the core of what we're trying to get to in every single person. Just another kind of spectrum of disease topic here. But the landscape is changing. It's changed from last year when I gave this talk to this year. I bet you in 25, this is gonna be longer. And then by maybe 26 or 27, this is gonna be a 2-hour talk. So get ready, guys, please sign. No, I'm just kidding, we're gonna keep it short. But these are, as of late last year even, these are all the registered clinical trials for other EGIDs and for eosinophilic esophagitis. And we'll see the different realms that they're in of monoclonal antibodies, immunomodulators, steroid, preparations, diet, and then there's other secret things that I'm not privy to. I'm sure someone much smarter than me can do that. So the landscape is changing. This is very confusing. This is why we have a talk about this whole subject. Currently available treatments, so PPIs are our mainstay, and a lot of our insurers will have us start there. They're topical glucocorticoids, so oral budesonide solutions. We'll talk about the newer FDA-approved ones that are pre-mixed, and we'll still kick it old school with mixing it with honey. Elimination diets I'll touch on, and then I say biologics, but right now there's one. It's dupilumab. So PPIs, per the AGA and Joint Task Force guidelines, are recommended over no treatment. That's excellent. So we should do something rather than nothing. There's no difference in which agent you choose when given at a higher dose. So in some studies, they've shown that maybe as you increase the dose, you're more likely to induce remission. So twice-a-day dosing has been proven to be better than once-a-day dosing from there. Overall, when you're talking to your patients and starting them on these twice-a-day PPIs, their general response rate is about 50-50 from there. The good things about them, they're easy to prescribe, no prior auth, generally, I hope, and they're well known, and they're generally pretty inexpensive for most payers. Oftentimes, at least, I know for myself, when we're going through Humana and TRICARE and everything like that, it kind of becomes our de facto first line, even though I must say that they are not, EOE is not an FDA-approved indication for PPI therapy. Something just to conclude there, but a lot of payers will make us fail a trial of PPIs prior to us starting any more advanced therapies. Again, I promised I wasn't going to belabor these points of cells and everything like that, but it works kind of through 2 means. We have anti-inflammatory effects, and actually it still does work on our gastric acid. The way it helps is, remember when I was all the way back at the beginning, we were talking about esophageal permeability and those allergens that you take in, preventing those from getting to the deeper layers of the esophagus, causing that inflammation, causing that fibrosis response. And otherwise, it actually prevents eosinophils from even getting to your esophagus in the first place. That's the big anti-inflammatory effect. Again, topical steroids, recommended over no treatment. So do something rather than nothing. That's all we need to know. Generally, these have a better response rate, about 65 to 75%. It does reduce the need for dilations in the future. That's been proven. And generally, they're safe and well tolerated. You can have some patients with oral candidiasis, and with some payers, that may be an indication to stop this therapy or say that there's a failure as well. There are long-term studies, but it's very rare given that it's generally budesonide that you're using of any adrenal insufficiency or osteoporosis or any of those long-term effects that we see with prednisone and other systemic glucocorticoids. Maintenance therapy length, we kind of have yet to sort of figure that out. Approved indications and approved formulations of this are used generally for about 12 weeks or so. And the last point here, this is on the old school indication of when we are using a meter. Can you believe this? We had people with a meter dose inhaler, so like an asthma budesonide, and they had to swallow the puff of air. I couldn't do that. I don't know how some of our patients can do that. And honestly, these were some studies from 2012 where they radio-labeled the budesonide. So this is someone who has a nice swallowed solution, and so they get in an X-ray machine. Okay, that's an esophagus. That's definitely. I wasn't good at anatomy, but that looks like stomach in there. But let's try our meter dose inhaler folks. Well, that's probably their mouth, and well, I don't think they have two stomachs. I don't think. So it generally tends to go in the lungs there. Not as excellent, kind of difficult to teach, difficult to treat. I know I certainly couldn't do that. So in our older formulations, again, these are in the old ACG guidelines, probably within the next month or two, definitely by the time of the fall meeting for the American College of Gastroenterology, there will be a new guideline of eosinophilic esophagitis coming out. But in the past, we were using fluticasone inhalers, and then patients had to mix or compound their own budesonide at home. So if they had the liquid, we'd mix it with sucralose, so kind of a non-sugar sweetener or Splenda. They do 1 to 2 milligrams of that twice a day. And then sometimes they get a compounded powder, mix that with honey or chocolate syrup. We're going for that like viscous consistency because they got to swallow it. They got to keep it in their esophagus. 30 to 60 minutes after, couldn't eat or drink anything. You got to keep it there. It's that topical effect that matters the most, not swallowing it and just washing it down with some liquid thereafter. But finally, we have a budesonide oral solution are available. The current dosing is 2 milligrams twice daily. This is FDA approved, and you can get it in pre-filled stick pack. So all the patient does, shake it, rip the top off, drink it, don't eat or drink anything afterwards for about 30 minutes. Treatment duration is 12 weeks. So the phase 3 trials of that, we can see they had a really stringent eosinophil count. Remember before I said 15 was where we got up? So they're like, all right, let's make it harder on ourselves. Let's go less than 6. And the patients who did, 53% of them got under that. If you don't do anything, only 1% actually improved their eosinophil count. So that's a huge difference, obviously. But the power of it as well is anything can make the eosinophils disappear. Is can the patients actually feel better? Can we make their endoscopies better? And that's where we see improvements in their dysphagia symptom response, a significant change, and their EREF score, losing 4 points on it versus only 2 in the placebo arm. So these do work. There are available options for 12 weeks to maybe induce remission in some of your patients, and some of these may be available sooner than other medications. That's a discussion for you, between you and your payers, unfortunately. Dietary therapies are really common. I get talked about this a lot with my patients. Maybe they don't want to be on a medication, and they're willing to make that leap to dietary therapy. So there's a few ones we can talk about. The first one is elemental diet. I promise you, no adult will do the elemental diet. It is horrible. It's like a baby formula of various amino acids. It tastes like kind of like a rotten fish. But it really works, but you're not eating anything. Could you imagine taking your entire life, everything you ate, that breakfast we just had, none of that. You can't have any of that. You're just sipping your formula, and that's how you live. So not really something that I use or would ever really use because I don't think it's a viable treatment option. There are elimination diets, and I have some of these ones up here. We'll talk about what we eliminate, and of course, can we tailor these to our patients? And those are very effective. About 70% will respond to it. And then there's allergy testing. So those are IgE-mediated tests, so the skin prick test diets. Those are about 50%, maybe a little bit less. So some poor evidence that that's really the best way to go from there. In the beginning, we had the 6 food elimination diet. So we took the 6 most common allergens. We had milk, wheat, eggs, soy, nuts, tree nuts, and fish, shellfish. Took all those out of their diet, and then we do an EGD. We take our biopsies. Did they improve? Okay, maybe they improved. Let's add 1 bag. Then, in reverse order generally, let's add 1 bag, do another EGD. After 8 weeks, let's add another bag. Wait 8 to 12 weeks, do another EGD. Let's add another and another. We kept doing that in this trial and error. So over the course of a year, someone's overgoing 6, 7, 8 EGDs with biopsies. It's kind of a long time to be changing your diet like that. So it was really hard to follow in any routine clinical practice. Recently, there's been a push, and I use this quite frequently in my patients. It works not as well, slightly less, but 65% of patients will have milk as their most common allergen that causes this. So a recent trial from last year showed that it had very similar results to the 6 food elimination diet. Cutting out dairy is easy compared to cutting out all those other things. That's what I start with my patients on. And again, here you see the percentage of patients, how I will approach my elimination diets, whether they can do 1 food elimination with just taking out dairy, or if they want to do 2, we'll take out wheat first, do our EGD here, and then go kind of in a stepwise fashion based on the probability that they'll actually have any response or any improvement based on removing these food groups here. And finally, the biologic, dupilumab is the biologic medication. It's the only FDA-approved long-term biologic therapy. It's This is old. It used to be 12 and up. I know we've had different indications right now. It's a subcutaneous, comes as a pen or an auto-injector pen or a syringe. 300 milligrams, that's just what's in the syringe. So they don't have to dose it, they don't have to measure it out or anything. Your patient don't have to measure it out. And it's given weekly for the EOE indication. Other indications have bi-weekly dosing. This one is weekly. The phase 3 study, again, improvements in histologic remission. Again, they kept it difficult at less than 6 eosinophils. Improvements in patient symptom score, so that's the Dysphagia symptom questionnaire, just a commonly used questionnaire for the purposes of studies. And highly effective, 83% histologic remission at 12 weeks. After you start the medication, you just individualize amongst the patient surveillance intervals. Generally about 8 to 12 weeks thereafter, you can do an EGD, check for response. Even in the study, when they continued beyond those endpoints to 24 weeks or beyond, there was still some improvements in histology that they captured. So depending on how your patient's feeling, how onerous they find the injections, you can continue this to keep seeing if you can get under those thresholds for treatment. And just how dupilumab works. The first time I heard about it, I was like, wait, I'm going to give my patients a biologic? I thought about infliximab, I thought about adalimumab, all those ones from the IBD realm where I've got to make sure that they're safe and they can get all these bad infections. Well, when I read about it, this one works a little differently. So again, not to belabor these points, dupilumab works on IL-4 and IL-13. That comes from the T2 helper T cells, which is more of an allergy immune response. This does not affect the normal immune response that you get to infections. It's not similar to the same kind of immune response of IBD or other immune diseases there. So a little bit safer. Just again, we see improvements in the dysphagia questionnaire scores from their baseline. Generally at around week 12, you'll see that true separation, but even earlier, we'll start to see some non-statistically significant separation in their dysphagia symptoms. So, as I mentioned, and this was said by Evan Dellin at DDW, said it again this year, it's not an immunosuppressant. It's not an immunosuppressant, it's not immunosuppressant. It works in a completely different pathway than all of this. There's no pre-prescription labs or any monitoring required. Immunogenicity, so when your body makes a response to it, was extremely rare. The package insert says 0 to 2, so we'll split the difference, say 1% or less in the trials, what they mentioned. There's very few adverse reactions. Injection site reactions are kind of most common as in the trials, but there was some nasopharyngitis and URIs. Right now, in terms of your pregnant or lactating patients, they have a registry to collect data on this, but no set guidance at this point for them. The issue sometimes that I've run into is insurance companies remain the gatekeepers for the drug, so they may require PPI or steroid failure. Just talk with your payers, talk with whoever is getting the medication for your patients, and see what the prior auths may require. And then finally, the last one, endoscopic therapy, is dilations. These are safe. Perforation is less than 1%, but I do tell my patients, you're going to wake up with some chest pain. So they may be calling you in the night saying, I'm having chest pain. Well, do your normal thing, make sure that they're okay, but oftentimes people will have it. I'd say about 75% of patients will have some degree of chest pain thereafter, but eventually they will see a rapid improvement, especially in their dysphagia symptoms. And the goal diameter is greater than 15 millimeters, 15 to 18 is where kind of I shoot for. This may take periods over time. I've had patients, the first dilation, I can get them to 9 millimeters. That's like a baby esophagus. So we work slowly over time. It has caused me to bring them back more frequently, do the dilations to get them feeling better. So finally, a little bit of an algorithm here that we can all use to guide our therapy. So once someone is diagnosed with the EOE, there's two branches of treatment, the fibrostenotic treatment and the anti-inflammatory. So on the anti-inflammatory side, that's where we're using our PPIs, maybe topical steroids, and or elimination diet. You can use these all in conjunction. If they have fibrostenotic disease, hopefully your endoscopist will do a dilation the first time he or she sees said ring, but you never know. Maybe they'll just decide to wait and bring them back. But hopefully they'll get that improvement at least first go. Once you get them on the therapy, assess the response. And that's through clinical assessment, how they're doing, going back all the way if they're doing those crazy eating behaviors, if it's taken them more than half a basketball game to finish a hot dog, and doing an EGD to assess their histologic response as well. If they're poor, if their response is poor, they're not getting under that 15 EOs or under 6, or even eliminating them, go back and consider other medical therapies. Sometimes that may be where we head towards dupilumab. But hopefully we can start bringing this up in our treatment algorithm, get our payers to cover this early on, so we can start using it more frequently in our patients. And then once they do have a good response, we just maintain therapy and monitor them. Generally for these people, once they're controlled, they're on a stable regimen, I bring them back only about once every year, do an EGD on them, just make sure everything's going good, check on them in clinic from there. And then a part of their ongoing symptoms when you do that reassessment is actually fibrostenotic disease. Then just follow up on an EGD, you'll see a stricture, and you can just do an endoscopic dilation. And setting them up on a future dilation plan from there. So hopefully we can move dupilumab up our treatment algorithm. Ways to get it maybe faster, consider other indications for it, see if you can get that approved through your payers more frequently. So I've taken enough of your time already. I think the caffeine is wearing off, the tacos are setting in, and I bored you enough. But EOE is a progressive eosinophilic disease of the esophagus with fibrostenotic remodeling. These complications from the fibrostenosis include food impactions, poor oral nutrition, and just general dysphagia as well. We have a whole host of therapies for this one. Hopefully, as these trials come about, we'll get them for other eosinophilic gastrointestinal disorders as well. But we'll always require therapeutic monitoring and assessment of endoscopic and symptomatic disease. So with that, thank you all for your attention. I'll turn it over to